Welcome to all the attendees and guest speaker to this new Sarcoma educational session with this IMPERAS project. Many thanks to join us. We want to dedicate this session to Professor Francisco Martinez Tello, who has recently passed away and has contributed a lot to the training of bone and soft tissues pathology here in Spain. Please mute your microphones during the presentation. You may send questions or remarks by using the chat or right after each presentation. Now it's my pleasure to introduce our first guest speaker. Is Dr. Elizabeth Montgomery. She is clinical professor and vice chair of faculty development of mentoring, director of surgical pathology fellowship training program, and co-director, pathology reference service, Miami, Florida. She is a very well-recognized international expert in soft tissue tumor and gastrointestinal tumor, and has contributed to many papers on these areas, as well as charter of WH Blue Books and ATRACS. So thank you very much, Elizabeth, for your time. And please, could you share your screen and start your presentation when you wish?
Okay, sorry about my telephone. So I will share a case that I didn't do a very good job on and use that for a discussion. Please excuse me. Hello? I'm giving a lecture, I'm really sorry. Okay, so this is a story of a needle biopsy of a large, very vascularized mass in the liver. Nothing else was affected, and I received a consultation on this case, H&E and CD34 stain. Reportedly, a keratin stain was negative. So here's the imaging. We can see this giant mass, and here's this tiny biopsy. This is a case from a long time ago, but I don't forget my mistakes. And you can see this lesion here. Here's more of it. And here's a CD34 stain. So, stupid me, I reported the case as epithelioid hemangioendothelioma. Then an operation was done. Let me move this. And a large mass was found involving the stomach. The liver had nothing. And of course, on this follow-up specimen, there was strong expression of CD117 and CD34. It was clearly a gastrointestinal stromal tumor. So don't forget about that, no matter where the biopsy is from. But let's talk about the real thing. Hepatic epithelioid hemangioendothelioma is rare, and it's infiltrative. It's not well marginated, like the case I showed. It can metastasize and result in patient death, and now liver transplantation can be used for treatment. So notice in epithelioid hemangioendothelioma of the liver that we see a very infiltrative growth pattern. So for example, a needle biopsy performed showing this focus would be non-diagnostic. This is a beautiful diagnostic needle biopsy. But if you're not thinking of this lesion, you will think it is a scar and nothing to worry about. Of course, we all know to look for these epithelioid cells with spaces. I think everyone in the meeting knows this, with a slight chondroid background. This happens to be a CD34 stain, and the beauty of it is that it allows you to highlight intracytoplasmic lumina. Here's one. And here's one, which is really actually more helpful than CAMTA in some ways. On the other hand, our forefathers in pathology often diagnosed cases like this as variants of cholangiocarcinoma. And it's very easy to see how these colleagues considered these lesions as adenocarcinomas. Of course, keratin expression is now a pitfall, un gato escondido, in modern practice. Of course, here are these intracytoplasmic lumina. Very easy to understand how a colleague could mistake these for mucin vacuoles. Nowadays, we have good stains. This is an ERG stain highlighting the endothelial nature of the lesion, but here's a keratin stain. This is a CAM 5.2. It stains the neoplasm, but not as strongly as the internal control hepatocytes. Of course, most of us, I'm sure in the group, know that most hemangioendotheliomas, epithelioid hemangioendotheliomas of the liver are primary, but we can see metastases. They are indolent and grow slowly. And of course, there are fusions that have been identified. This is the classic one with CAMTA1, but there's a subset with TFE3 fusions that can be diagnosed by immunostaining for TFE3, and it's more likely to produce round vessels. In fact, there's a move to call the ones that have TFE3 expression instead YAP1 TFE3 fused hemangioendothelioma rather than call it a part of epithelioid hemangioendothelioma. I'm an old lady, so for me, epithelioid hemangioendothelioma is an H&E diagnosis and very easy. This is one involving the lung. Chondroid background, intracytoplasmic lumina, and sometimes even an erythrocyte found in those, probably artifactually. However, I have sometimes had great difficulty diagnosing epithelioid hemangioendothelioma without using modern immunohistochemistry. This is an example of the soft tissue that was very, very spindled, and I made a lot of stupid immunostains, and finally, oh my goodness, this must be an epithelioid hemangioendothelioma, and I could confirm it with specific immunohistochemistry. But it took me a long time. This is a cell probably with an intracytoplasmic lumen, but I did not initially appreciate those cells. This is another impossible variant of epithelioid hemangioendothelioma. This was a pleural mass that was clinically believed to be a mesothelioma. It's obviously solid and high grade, and eventually I reached the diagnosis after some silly ideas. Here are some more errors. Let's look at a biopsy of a liver mass. This one I did not do, but I could have. Here it is. Please enjoy it. Sclerotic tissue, lesion, more lesion. Notice that it seems to be vasoformative. More of the lesion. And very high magnification of an area that showed a lot of atypical nuclei. Hopefully many of you recognize this. So think for a moment. And of course, this is simply spleen tissue. So the next time you see a spleen, be sure that you look at high power and see all the big atypical cells, but then remember to see the vessels. And they're highlighted with CD8, which is very unique to spleen tissue and can save you from making a fool of yourself. Another liver biopsy. This was diagnosed as hepatocellular carcinoma. Here are some hepatocytes adjoining or right next to the lesion. Here's the lesion. Easy to see how someone could make such an error. Higher magnification. And this, of course, is a pecoma. This is an HMB45 stain. So yet another way to be foolish. Pecomas. Okay, so they can be spindled or epithelioid, clear or granular. They have a perivascular arrangement. They have a myomelanocytic immunophenotype. And if you do ultrastructure or electron microscopy, you can find melanosomes. Most pecomas harbor TSC gene alterations, that is tuberous sclerosis complex, so they respond to mechanistic target of rapamycin or mTOR inhibitors. Some people call them rapalogs, such as rapamycin, temsirolimus, everolimus, and then the newer ones. Unfortunately, also with PCOMAs, a subset of such tumors has TFE3 rearrangements and does not respond to mTOR inhibitors. So this is a classic composite of how PCOMAs can appear. They can be spindly, but they look a little bit clear. So I know I, in the past, once misdiagnosed one as clear cell sarcoma in the days before modern immunohistochemistry. And here is a composite of the usual immunostaining pattern for PCOMA. This is HMB45. I don't know what I did to the label. Ah, there it is. And another important pitfall is sometimes in the liver, PCOMA can mimic liposarcoma if you don't think of it. Liposarcoma would not be expected to have these large eosinophilic cells. This is an example of a TFE3 rearranged PCOMA. Notice that it presented as a colon polyp. Oh my gosh. And this type expresses melanocytic markers, but it doesn't express the smooth muscle markers, and it's unassociated with TSC genes. This one is at higher magnification from the polyp. I initially considered the possibility of an alveolar soft part sarcoma for this tumor, and you can see why it looks very similar. Here it is at higher magnification, and it expressed HMB45, which would be very unusual for an alveolar soft part sarcoma, and it also stained strongly with TFE3. Notice the macronucleoli in each cell. So in summary, if you have a needle biopsy and the findings don't quite make sense, always consider that a different structure has been sampled from the expected one. And don't be an idiot like me. Always have gastrointestinal stromal tumor in the back of your mind in biopsies from the liver or from abdominal masses. Thank you very much.
Thank you very much, Elizabeth, for this nice presentation and the beautiful pictures. I have a question for you. You know that some carcinoma may have a sinusoidal liver infiltration, and maybe it could be hard to distinguish this carcinoma with sinusoidal infiltration of the liver from epithelioid hemangioendothelioma. I mean, without immunohistochemistry, of course. In your experience, cytokeratin expression in epithelioid hemangioendothelioma is as strong as in carcinoma or no?
I agree. It's usually not as strong as in carcinoma, but it can be in occasional cases. But it is a small clue. If you see weak keratin expression, think about endothelial.
Okay. Yeah. Any further question to Dr. Elizabeth? Professor John Barr, Sergio, Rodolfo, Haydee.
Entonces, muchas gracias para invitarme.
Thank you very much, Elizabeth. Any further question, please? Professor John Barr?
Está muted.
Muted.
Okay.
Okay.
Can you hear me?
Yes.
Congratulations for your very nice presentation. Do you use FISH analysis or molecular biology to confirm this diagnosis, or do you think that is not necessary for that in that cases?
Quite honestly, I work in an institution that does not have FISH or molecular biology, so I use immunohistochemistry.
I see you have a picture of Cajal in your desk.
I do. There he is.
Yes. As you know, Cajal was the man who described interstitial cells for his. Do you have any idea of the relation between the primitive ideas of Cajal and the actual thinking about yeast tumors?
No, acabo de comprar su libro, el libro de Cajal, pero no, no lo he leído.
You must read it.
Not yet. No todavía.
Congratulations.
Para practicar español, he comprado el libro, pero es muy difícil a leer.
In Miami, you had possibilities to speak Spanish because almost half of the population doesn't speak it.
Sí. Soy la sola persona hablando inglés aquí.
Any further questions? Sylvia? Sylvia is here. Sylvia Baguette. Anyone? Is there a question in the chat box, Elizabeth? Are you able to see the chat box? Elizabeth? Are you able to see the chat box, or you may want to read the question?
So a colleague has mentioned that sarcomas have different nuclear size and forms, small nuclei, subtle irregular karyoteca, where nuclei did, how do you categorize as high grade? I have a great deal of difficulty with this, as others do, and I know many have preferred to use mitotic rates. Perhaps one of the colleagues here has some good ideas about that.
Any further question or remarks? So Elizabeth, thank you very much for your time. We continue with the next speaker. Our second speaker is Dr. Haydee Caro. She is oncopathology from sarcoma and head and neck tumor for National Cancer Institute from Mexico. She has a special interest in bone and soft tissue tumors. We really appreciate your participation, Haydee. And please, could you share the screen if you don't mind? And start.
Yes, hi everybody.
Hi.
Okay. Wait. Can you see it?
Yes.
Yeah.
Okay.
Okay. This is, thank you for inviting me. It's a very good opportunity to see another people here. So I'm going to show you a case that is bothering me because it's a non-conclusive case. So let us start. This is a 29-year-old male patient that started in 2020 with pain and swelling of the left shoulder. Then he went to a orthopedic surgeon who did a resection. We don't know if it was taken completely or whatever, we don't know. So what do we have? We have the patient went to, after this tumor, he went to another place here in this country where it's a sarcoma center. So they found a soft tissue tumor and that was affecting the bone also, and it was very big. They did or they performed a biopsy that was with the diagnosis of Ewing sarcoma. After that, the patient came to us, and at late March, and we didn't have that material where the biopsy or the Ewing sarcoma was made. So he got lost, he didn't came back, and they only did some studies to see the affection of the tumor, but we didn't have the material. So we can see here, this is in February of 2021. So we can see here that is a very big tumor in the left shoulder that was also with a fracture in the head of the humerus. So we see that the bone is affected, but we don't see it like the tumor is coming from the bone. We think so, but after we see these images, we can see that the tumor is very big. It has a lot of necrosis. It's not yet in the skin or affecting the skin, but it's a very large tumor that is affecting the bone. We can see the pieces of the humerus there. So the patient, as I said, went lost until November 2021, when he came back with the material, and we can see that he came back because he was in a very big pain, and the tumor also was bigger, and it has an ulcer. So the patient started to feel a lot of symptoms. We think that it was infected or over-infected. They started a new studies like CT scan, endoscopy, laboratories, etc. They, if we can remember, the patient came with the sarcoma, Ewing sarcoma tumor. So when we have this material, we can see here that is a very blue small cell tumor. There has a lot of necrosis, and we can see here that it has no final pattern. We can see that it's all solid with a very sparse necrosis. So when we finally can see the detail of the cells, we can it does have a lot of cytoplasm. The nucleus is very hyperchromatic, and we can see also that it has a very a few rosette formation, we can say that, or maybe I want to see those because it has the diagnosis of Ewing sarcomas. So when we see the rest of the material is the same. Everything it looks like a small cell tumor, right? But the patient in the studies, the screening didn't have another tumor, didn't have lung metastasis. It was only a lymph node in the axillary region, but that's it. So the whole problem was the very big tumor that was on the shoulder. So when we try to see the detail, sometimes I wanted to see some spot pattern in the nucleus, but it was in the areas of necrosis, so we didn't take it too seriously. So as a very small blue cell tumor, we performed a lot of immunohistochemistry because our diagnosis in this patient was very large. So the options were this. Ewing sarcoma, as it came to the hospital, because you see osteosarcoma, mesenchymal chondrosarcoma, the different chondrosarcoma, a lot of, these tumors are like a very big pain for us, but they're also very interesting. So also because he was a young patient, we have to take it to like hematolymphoid tumors, because we have an experience of 14 cases that was lympho primary of the bone in that case. So I always think about that. And here is the immunohistochemistry. So I only going to show you some of this immunohistochemistry because it was a lot, really a lot. And the Ki-67 was very high. The key, we think about something that was plasmocytic, it wasn't. NKX2.2 was negative, EGR was negative, FLE was negative, CD99 completely negative, ENMS1 was very focal, that was a surprise. And then we performed CD66 and synaptophysin. And this was the result. For our own amusement, this is the result. So what do we do now? It's a neuroendocrine tumor metastasized to the bone and the soft tissues of the humerus without any activity in any other part. It has, it is primary of those of the tumor of the bone, where we don't think so, or is an aberrant expression in a urosarcoma. So what do you think so far? This is the immunohistochemistry that we performed. It was a lot because it was a very difficult tumor to categorize. And also because it doesn't have the classic image of a urosarcoma. So we have 3 markers that doesn't help to say it is a urosarcoma. It was very weird to see, or is going to be very weird to see a urosarcoma with CD99 negative. So what do you think so far? Any ideas?
I would like to express my opinion.
Yes.
It could be an adult neuroblastoma because these 2 markers, this is a small round blue cell tumor expressing synaptophysin and CD56. The other markers negative, we have to discard a neuroblastoma, adult neuroblastoma.
In the bone, in the arm, like a primary.
Metastatic, right? or
Okay, yeah. Okay, I'm going to continue with the story. Anyone else wants to? Yeah. Yeah.
Yes. Well, that is an interesting case up to now. I think, well, Sammy Navarro maybe has right with adult neuroblastoma, but as you have shown in the histology, cells are too big, too dark, as to be a conventional Ewing sarcoma. From my point of view, the presence of neuroendocrine markers, as we have seen in Ewing's and Ewing-like sarcomas, might be positive in some cases. That's not exclude a small rod cell tumor of sarcomas group. So from my point of view, it looks more like a BCOR positive tumor or a C1 neoplasma than a conventional Ewing sarcoma. But I will stress the possibility of this unusual variance of Ewing-like sarcomas up to now. If you follow and give us more ideas, I will thank you.
Yeah, we also thought about that, and the WT1 was negative and the SATB2 was negative. We use it as the partner because we are expecting to have the BCOR and the ETB4 immunohistochemistry, but it's not yet here. So we think that is not a very usual Ewing sarcoma. That's exactly what we think. So we discard everything else, but it was lucky to send the diagnosis like this because we cannot support the sarcoma, Ewing sarcoma in this case. So because of the confusion, the patient was in pain and everything. I will show you later. Small cell blue neoplasm was a diagnosis. It means not carcinoma metastatic. But we did a lot of the rest of the immunohistochemistry that we can show you, that I show you. And then he got lost and came back. So the patient was in a lot of pain. We can know why, but we also see that the tumor has some air in it, trapped. So it has an abscess, or is start to screen for the rest of the body. And one radiologist said it has something weird in the retroperitoneum, but they didn't manage to get a new image. So it was like in there. They didn't put it in the report. They didn't say anything, just name it. No. So what did we do? We presented this case in CellNet, and patients even for the tumor, that interscapular thoracic surgery must be performed. After that, and the extremity wasn't able to be saved. So after that, they can do endoscopy. It was performed. The rest of the PET scan didn't show any activity. Just the thing in the bone and in the arm. That's it, and some lymph nodes. The rest, it was clean. So in the inter, we used the tissue that I was taking in my hospital, and we, just for curiosity, we performed a fish. We don't have the partner, but we did it, and it was positive for EWSR1. We don't have the partner, so we don't know exactly what it means. We know that there are a lot of tumors that are this, this gene is promiscuous, as Dr. Dominguez says. And for our surprise, it was positive. So in the inter, we have the resection, the piece. So we can see here is a very big tumor with a big ulcer. And when we cut it, we can see that it has a lot of necrosis, and the fractures are evident. It was, this was the reason that he was in great pain. So we found some of lymph nodes that were positive microscopically, and we see the same neoplasm. It was also like a small tumor. We found some formation of rosets, but it's not very clear. We found the same image in all the tumor. It doesn't have any osteoid. It doesn't have any production of anything. It is the same tumor. So we performed, because this is not correct. Maybe we made a mistake. I don't know. The clinical surgeon said, no, it's not possible to be an neuroendocrine neoplasm metastatic because we didn't find it, etc. You know them. So we performed again this new histochemistry, and it was the same. So we found again CD56, but it's not in parts. I mean, it's not in spots. It's diffuse and it's intense. So what do we say now? Well, we said the same. We don't know where it came from. We know that they can be primary, that we don't know where is it. It is very usual for a neuroendocrine carcinoma to do this, but we don't know where is it. So it's very weird that it didn't show up or blow up with the PT-CT scan. So I don't know what you think until now. It was positive in 2 of 24 lymph nodes, and it was around the soft tissue of those lymph nodes. So they performed this, and they didn't find anything in the pancreas. It was like artificial in the previous image. So they said it has nothing. So we're stuck at the beginning. So we don't know where it comes from. The point of this case is to show you how, or to share with you this case, because it's something that, how do we call it? And we call it a small cell carcinoma metastatic, a primary Ewing sarcoma with expression, but it was EWSR1 positive, but CD99 was negative. So the rest of the markers didn't show or was expected to be B-core, or because of the W21 and the ETB4, we don't have it, but SAT-B2 was negative. So what do we do now? Well, searching, I found that there are a lot of literature about mesenchymal non-epithelial mimickers with neuroendocrine neoplasm with a lot of these alterations, molecular alterations. Also, I found one paper that was made by you, Dr. Lombard, and Isidro. So it was very helpful, but I don't know what to do now, because look, the mimickers of the neuroendocrine tumors, there are a lot. And when they perform these markers, they did synaptophysin, chromogranin, they perform ENM-S1, and they perform also Ki-67, etc. They found that they can be present, but it's not diffuse. I mean, some of those can express those markers, but it's never in a diffuse pattern. So they say that a lot of these kind of small cell tumors can be positive to these markers, but we can, or we have to perform molecular studies. But here is the big complexity. What do we do with the EWRS1 and it was negative CD99? So the total expression, as I told you, is very different. They do research the internet and a lot of papers, and they found this. They found that it can be present in different types of tumors, and it can be present in a very different ways. So what do we do? Well, it's a standby tumor. I mean, we don't know if we can leave that name to it. We talk to the clinicians, but they say that if it's a known origin and neuroendocrine carcinoma, it has to pop up in some point, but we don't know. And then this is the article that you did. I found you, I got you. So I found that very interesting because the expression of the different types of markers were present. And you also found that it was not diffuse. And when it was intense and diffuse, as the same as CD56, sometimes it supported that it was a different differentiation of neuroendocrine tumors. But if I understand it well, it was more for prognostic, and that the CD56 lower negative have a progression for free survival of 10 years. But if it was a hyper expression, it was lower than 38. But this is the images or the picture that you show in the article, and none of those were diffuse. So if you remember the expression in our case, it's different. So the only one that was similar to us was this one. But CD99 was negative, totally negative. So then, trying to make sense of it, I found something like this, that it can be found metastatic, but it's not the more common. Sometimes, or the article says it's a tumor, for example, in this case was a 71-year-old male with a prostatic cancer that was with some parts of neuroendocrine differentiation. So it was a mixed tumor. It wasn't just neuroendocrine tumor. So I don't know what you think until now. Any questions? I have a lot, so.
This is a very difficult case. You may see the shark's box. I don't know if you have time to see
no,
the
I wasn't.
box.
I know that was 23 marks, but I'm afraid that.
No, only a comment. For me, I don't know the opinion of Elizabeth, Professor John Barr, Enrique, Samuel, and the other attendees. For me, it's very hard to believe in neuroendocrine tumor without keratin expression. In this case, I mean, so it's really difficult to make a diagnosis in this case without know the partner of the EWS.
Yeah.
Consider that solid extraskeletal myxoid chondrosarcoma, for instance, may have a strong and diffuse neuroendocrine expression and may have in Ewing sarcoma EWS translocation. So I think that would be mandatory in this case to know the specific partner for EWS. I don't know. I would like to know the opinion of Elizabeth, Enrique.
Yeah, this needs to be sequenced, or it needs to have next generation techniques. I also suspect it's around blue cell sarcoma with aberrant synapto, but it has to be proven.
¿Me oís, Isidro?
Yes.
Soy Cleo.
Yes.
Thank
yes.
you. Sorry.
Sí.
I would like to ask you, Haydee, it's a very nice case and difficult case, obviously. Have you done this CD 117, the SECIT?
Yes, we did it. It was too much. I didn't put it, but we did it. It was negative.
Okay, because sometimes in extraskeletal myxoid chondrosarcoma, it's positive and it can help, but it can be negative also. So it's next generation. No way.
That's why I wanted to share it because it is very difficult. Sometimes we don't know what to do. So in this case, I don't know what to do. So I talked to the clinic and says, okay, put it like that. But if it is that, maybe it will show in some point. If it's not, well, we can treat it like small cell tumors with no, last name. I don't know. So that's why I wanted to share this with you.
Dr.
I think,
yes.
I think that,
Ciao.
So I think that is one of the cases in which NGS can be used. I don't like too much because generally when you have a good fish or PCR, you can reach that. But I think that as a lot of people wrote, it's important to know the gene pattern of our EWS, because if we have a gene pattern related, for example, extraskeletal myxoid chondrosarcoma, or we have the answer, despite of synaptophysin that if it is can be also a new tumor, and I think that we are ethically obliged to find some new tumor, maybe, I don't know. Of course, the oncology will not have a specific therapy if we find something new, but we can discover some new entities.
Yeah, because if it's a BCOR or CXDUX, is not going to have a specific treatment.
But I think that with EWS, we can rule out, because you have EWS. So SIC BCOR does not have EWS. So I think that we can rule out both. But in any case, there are EWS, I don't know, it is not the morphology, but MFAS-C2, PATH1 or other, I think it's not the morphology, but some other cases that can be, that some other entity that can be discovered with NGS. I don't like very much to use this because it's very expensive, but in this case can be useful.
Yeah, and the patient obviously doesn't have the resources to perform those. That's the reality.
The problem.
Yeah, also. So we don't know. Dr. Enrique.
Dr. Enrique,
yeah, I haven't the faintest idea of what is that, but I think this is not a Ewing sarcoma. This could be an extraskeletal myxoid chondrosarcoma, but I noticed that the case is mainly in the bone, so I don't know what's that. I wouldn't spend that amount of time discussing that. I would make NGS and that's it. If you send the case through IMPERAS, we'll do NGS for you, okay?
Oh, great. Thank you. Yeah, because we really, I don't know how to name it.
Yeah, I don't either, but I'm sure that the NGS will help us a little bit on this.
Okay, thank you.
Yeah, thank you. Thank you very much, Haydee. Thank you very much to all the attendees for the participation. Haydee, please, could you stop to share your screen?
Yes.
Okay. Okay, we continue with our third speaker, is Dr. Rodolfo Guzmán. He is pathology from Hospital San Juan de Dios, San Jose, Costa Rica. He is professor from the School of Medicine, University of Costa Rica, and also have a special interest in bone and soft tissue tumor. So Rodolfo, thank you very much for your time and your contribution to this session. Could you share your screen and start the presentation if you wish?
Thank you so much for inviting me. And can you see my screen?
Yes.
Okay, so I'll start right away with the case. My case is on a 74-year-old male who presented with a history of 1 month of acute memory loss and also with difficulty for reading comprehension and also for writing, making calculations. And besides that, the 2 weeks before, he developed a headache. On physical examination, it was surprising that there were no sensory motor alterations and a left flank lipoma, about 3 centimeters in largest diameter, was noted clinically. On the head MRI, they found a left parieto-occipital tumor that measured 47 millimeters, also with hemorrhage or calcification, and perilesional edema and a middle shift to the right. I'm sorry, but I don't have any imaging for you because in the past few months, our institution has been hacked by a group of foreign hackers. So the digital chart for our patients, our biopsy system is down. So it was very difficult for me to gather all the information. So they performed a biopsy on this patient's tumor that was in the brain. So on the left, we can see the cerebral tissue alongside with a spindle cell tumor. The brain tissue has a lot of edema, and the spindle cell proliferation, the medium magnification is very pleomorphic. It also had foci of osteogenic differentiation and also chondroblastic differentiation. And you can see the cellular pleomorphism and the presence of osteoid in a lace-like pattern, a pericellular pattern. And there were also, luckily, foci of mineralization of this extracellular matrix. We found, besides the pleomorphism of the nuclei, lots of mitotic figures. Many of them were atypical. And there was also necrosis of the tumor. So a GFAP was performed, and the cerebral tissue that was that you can see in the upper left is positive, but the spindle cell proliferation is negative, with only remaining tissue of that expressed GFAP at the periphery of the tumor. So this first biopsy of this patient was diagnosed as an osteosarcoma, probably metastatic, and it was advised to check the patient for primary elsewhere. The post-op head CT showed no residual tumor, luckily. So back to physical examination. the patient was reported to have a left flank mass that was clinically regarded as a lipoma. So they requested me for a second opinion on biopsy 1. I don't do neuropathology. So I got to know that it had an osteogenic differentiation, but was also able to perform at least these two markers. SATB2, that we had to send the tissue to another hospital, Hospital Mexico, which is another main hospital in San Jose. And it turned out that the nuclei were diffusely positive for SATB2, whereas MDM2 was negative, because I was also thinking on a possible metastasis of the deep liposarcoma. So my opinion was that given that there were no areas of glial differentiation and GFAP was negative, so I agreed with the first pathologist that it was probably high-grade metastatic osteosarcoma. They performed a trunk CT and they characterized the mass furtherly. It measured 32 millimeters at the moment of the CT, and it infiltrated the left internal and external oblique muscles, and it was independent from the ribs. And they also found a small mass in the right lung. So they performed a second biopsy, which was a corneal biopsy of the left flank mass, which I show you here. So we found necrotic tumor on the left and a spindle subproliferation on the right, which also was pleomorphic and had an extracellular matrix. Had a lot of pleomorphism and plenty of mitotic figures. And luckily, we found osteoblastic and chondroblastic components, also pleomorphic, and no lipogenic differentiation, at least morphologically. I performed SATB2 again on this new biopsy, and it turned out also positive diffusely, and the MDM2 was also negative. So this case was regarded as a high-grade pleomorphic sarcoma consistent with extraskeletal osteosarcoma grade 3. So with that diagnosis, they decided to perform a resection of the left flank mass and also of the segment that was affected in the right lung. So in order to remember, the third segment of the right lung is the anterior segment of the upper lobe. And this is the third biopsy that was performed on this patient, which is a soft tissue mass that was very cellular, and it showed no lipogenic differentiation morphologically. And it also had plenty of osteoid with mineralization and also necrosis. There were fascicles also with pleomorphic cells and also anaplastic cells with atypical mitotic figures, such as this one with a butterfly shape. And we found that there was also a clear osteoblastic component with mineralization of the extracellular matrix and also chondroblastic component. Most of the margins were wide with clear recognizable normal soft tissue, but the superior margin was marginal with only the pseudocapsule around the tumor. On the specimen of the right lung, we found a subpleural tumor that showed also the same findings that we had seen, and the margin was uninvolved. So this case is regarded as an extraskeletal osteosarcoma, grade 3, with this staging PT2, given that the tumor was 6 centimeters in largest diameter, and PM1, because we could find metastasis in the brain and also in the right lung. So to summarize the case, it was a 74-year-old male who presented with neurological symptoms but those symptoms turned out to be the result of a brain metastasis. And he also had an asymptomatic right lung mass that turned out also to be a metastasis. And the primary tumor was an asymptomatic soft tissue mass in the left flank that was an extraskeletal high-grade osteosarcoma. So a few comments on this. Can a malignant bone-forming tumor in the brain be primary? Sad news is that yes, it can. So we have to consider local entities such as glioblastoma, which is described to being able to have mesenchymal metaplasia, as in mature soft tissue component or heterologous components, and also sarcomatous metaplasia, in which there are foci of clearly malignant mesenchymal neoplasm. And there is also the gliosarcoma, which is a subtype of glioblastoma, which is defined as a biphasic neoplasm with alternating glial and mesenchymal differentiation. This is known for quite some time, and the way that we can show the glial component is not only by morphology, but with immunohistochemistry using GFAP and other markers as well. And this is a recent case report that they used the immunohistochemistry for SATB2 in order to confirm the osteogenic differentiation in this case. Gliosarcomas are very rare. Around 2% of glioblastomas can be de novo or can present after conventional adjuvant treatment for high-grade glioma. And the glial component can express glial markers such as GFAP or OLE2. And the sarcomatous component is usually negative or only focally positive. And it is believed that the gliosarcoma is a phenotypic change in glioblastoma cells. Because they have both components, they have common molecular abnormalities. So what do we do with SATB2, and how reliable is it as a marker for osteogenic differentiation? Its role in bone tumors is well established, whereas in soft tissue tumors, given their scarcity, is still to be in debate. For example, in this paper by Connor and Hornick from a few years ago, they showed that 8 out of 9 extraskeletal osteosarcomas expressed SATB2, but there are also other soft tissue entities that can have osteogenic differentiation, mainly the diff liposarcoma and also leiomyosarcoma and malignant peripheral nerve sheath tumors, which can have a heterologous differentiation. For example, here in the upper right, you can see the diff liposarcoma, which can have foci of osteogenic differentiation as well as expression of SATB2. And in the lower half of the screen, you can see the MPNST. They can have focal heterologous components of bone-forming neoplastic cells, which can also express SATB2. And what else? What about the osteogenic differentiation in the diff liposarcoma? Is it important to recognize it? It turns out that the presence of ossification in the diff liposarcoma is associated with shorter local recurrence-free survival. And the metaplastic appearing ossification, such as in the upper central part of the screen, in the as in a very differentiated bone trabeculae or bone tissue, it showed a tendency for longer overall survival, but was not statistically significant. And it can also show SATB2 expression. And this has also been addressed by the group of Valencia, along with the people from the Rizzoli Institute, but mainly for bone sarcomas, in which they established a role for differentiating osteogenic expression that leads to osteosarcoma, and it can be of utility to distinguish it from other mimickers, such as Ewing sarcoma or even chondrosarcoma. And they reported that SADB2 can be present also in reactive woven bone and in the endothelial cells within the tumor. So just to finish, there's very few to add about extraskeletal osteosarcoma. It's a sarcoma with a very poor prognosis. It's a very rare sarcoma, and only 4% of all osteosarcomas. And the main thing is that we have to demonstrate that it has no connection to the skeletal system. The factors that are associated with poor prognosis are distant metastasis, an age over 60 years, such as our case, and a size over 10 centimeters. It can be very similar to its skeletal counterparts because of the histological subtypes. And a reverse zoning pattern is very important to recognize because it can mimic one of the main differentials in soft tissue tumors, myositis ossificans, for example, which can have mature bone at the periphery and immature cells at the center. The treatment is multimodal. It requires surgery and adjuvant chemotherapy and radiotherapy, but there's controversy on the utility of chemotherapy because its utility is based mainly on retrospective studies because of limited number of patients and because of different treatments used in a lot of years. So that was my case, and I'm happy to let you know that today we celebrate our independence. In fact, it's a celebration in all Central America, in our 5 countries, and it is a process that started in 1821, and there was a failed intent of performing Central American Federation of countries. But in 1848, there was established the Republic of Costa Rica, which is what we are now nowadays. And I regard that international cooperation and interdependence is very important for us to establish networks and in order to support us as a country and as well as pathologists. And it is my pleasure to announce that we are officially a partner of CellNet, which is the Sarcoma European Latin American Network, and that we will be hosting the next consortium meeting next November. So I hope to see some of you next November. You are all invited. And thank you so much for your attention. And I'll leave you with this photograph of our anatomic pathology service with our 2 hematoxylin trees. The bigger was recently cut because of a problem, but we have another one growing in process. So I'm happy to hear all of your feedback. Thank you so much.
So thank you very much, Rodolfo, for this interesting case. Are you able to see the chat box?
No, not yet.
I invite you to see the chat box. In the meantime, for instance, Sylvia, do you want to give your opinion about this case? Because you gives some alternative diagnosis possibility.
Okay, an MPNST with bone. Yes, that was a possibility. I didn't show it, but the S100 came back negative, and also the GFAP. We do not have the trimethylated histone yet in our country, so it is quite a problem because since it is a better marker for MPNST, we still do not have it. But yes, it is also of consideration.
Any further question or remark, Elizabeth? Professor John Barr?
I agree with you. I think this is a nice case that it is metastasis, probably of an extraskeletal soft tissue osteosarcoma, because the opposite, to be a primary central nervous system tumor, they does not used to metastasize outside the central nervous system. Only some glioblastomas, high-grade glioblastomas, that's it. We have seen also that some malignant peripheral neural cell tumors, they show bone metaplasia, but it's focal. It's never so extensive. And in your case, you see in all your metastases, you have bone.
Yes, that's correct.
So, any further questions or remarks?
I
think that
there's also the possibility of belonging to the meninges. So yes, meningeal tumors are obliged differential diagnosis, and at least this case did not have a relation with the meninges. And there are a few cases reported for intracranial osteosarcoma being primary, which is also a consideration. But given that we found a soft tissue tumor, well, we decided to blame it as the primary.
Okay. Any further comments or remarks? Okay. Thank you, Rodolfo, for your nice case and your presentation.
Thank you so much for inviting me.
And our last speaker is Dr. Eréndira Estrada. She is attending pathology from Instituto Nacional of Rehabilitation, Ciudad de Mexico. Eréndira, areas of interest include also bone orthosis tumors. Eréndira, thank you for your contribution to this session and for your time. Please share your screen and start your presentation when you wish. Eréndira, are you still there? Eréndira, can you hear us?
Yes, hello?
Okay, are you still?
Well, first of all, I want to thank to Haydee, Caro, because she introduced me with Dr. Machado, and I want to thank Dr. Machado because he allowed me to share this case with you. I start. It doesn't advance. It doesn't advance.
Okay. One.
Well, this case is about a 30-year-old woman that came to the hospital with a history of pain and increased volume in the distal portion of the thigh, and the duration was of 4 months. Here I present to you the radiographies. In the left is the anterior-posterior radiography, in which we can see a radio-opaque lesion in the distal femur, but also we can see a radiolucent lesion in the most distal portion of the femur. And in the lateral radiography, we can see the localization of this lesion, and we can see that this is a superficial lesion and that is present in the distal portion of the femurs adjacent to the cortical part of the femur. here I show you other studies in which in the left, we can see that there is a cortical disruption of the femur, and that there is also intramedullary involvement of the distal part of the femur. And in the right image, we can see that the lesion has two portions that are different in characteristics in the image. So there was realized a tomography of the patient that showed subpleural and parenchymatous nodules, and the report was of metastatic tumoral activity in both lungs. And the patient had other studies like mammography that report slight increment in metabolic activity in the distal femur. With all this clinical information, the diagnosis was of a dedifferentiated parosteal osteosarcoma. So the orthopedist made find a core biopsy, and I show you the material we saw in this first biopsy. We made a descriptive diagnosis of adipose tissue, hemorrhage, and reactive bone. Then the orthopedist take a second biopsy, and this biopsy was also identified like a biopsy of the intramedullary component of the tumor. And I show you what we saw. We only saw fibrous tissue, or what we interpreted in that moment like fibrous tissue. We saw a little of residual trabeculas, and we made a descriptive diagnosis only, in which we report connective tissue, and we consider that the biopsy was not representative of the bone tumor and suggest to take another biopsy. So the orthopedist went to the pathology service, and he told us, "What's wrong with you? I have sent to you 2 intramedullary biopsies and you only see fibrous tissue." And we respond, "What's wrong with you that you don't take a representative biopsy?" Then he took another third biopsy, in which we saw, well, I put here the diagnosis. Here we saw the parallel disposition of trabecules and the fibrous tissue without atypia in the nuclei, like here, see? And only in this third biopsy, we made the diagnosis of a parosteal osteosarcoma. In that moment, nobody made the question about this is, because this third biopsy was of the superficial portion of the tumor, but not of the intramedullary portion of the tumor. And nobody made the question about what happened with the intramedullary portion. So the diagnosis was left like a parosteal osteosarcoma, and then we received the blood resection. In the right is the blood resection, and I put here also the images that I showed previously to you. And well, when I cut the piece, I was in shock, and I went in the first crisis, because I saw what I expected, the superficial portion of the tumor, but also I saw the intramedullary portion of the tumor that for me was very rare. The superficial portion of the tumor was very hard, was slightly pink, but the intramedullary portion of the tumor was white and was and had a fibrous appearance. But when and here I try to remark the difference between these two portions. Here I show you the slides that correspond to the superficial portion of the tumor, and that I think that everybody thinks that is a parosteal osteosarcoma. Here, this is a higher magnification of this portion. And here is a slide of what I consider the transition zone between the superficial portion and the intramedular portion with a different histological aspect. Here is the histological aspect of the intramedular portion of the tumor, in which we can see that is a fusocellular tumor. This intramedular component has a very bland nuclei. We saw no signs of necrosis. There were no atypical mitosis, and we considered that this intramedular component was a low-grade component. That's why I was in crisis, because normally one expects to see in a dedifferentiated parosteal osteosarcoma a high-grade component. So I went to my professor, Dr. Dominguez, and showed him the case, and we made a lot of considerations. And I want to share to you these considerations, because typically when we talk about dedifferentiations in bone tumors, generally we use this term when a high-grade sarcoma develops in association with a pre-existing aggressive low-grade sarcoma. By example, the dedifferentiated chondrosarcoma. And I put here a point here, the abrupt transition between the two components. But what about if a low-grade malignant tumors dedifferentiate in a low-grade neoplasm? This can happen? Well, the answer is yes. And by example, we have dedifferentiated cases of liposarcoma that dedifferentiate in a low-grade sarcoma. So the question, and I invite to you to first open your mind, and second, make a change in paradigm and consider that maybe not only liposarcomas can have low-grade dedifferentiation, but also parosteal osteosarcomas can have it. And I mention this because we have tried to publish this case, and the reviewers have told us that this type of dedifferentiation in bone tumors can't be possible. So the diagnosis of this case I present to you is of a dedifferentiated parosteal osteosarcoma, in which the differentiated component is a low-grade fibrosarcoma. We made immunohistochemistry. Unfortunately, in my hospital, we don't have many antibodies. Difficultly, we have immunohistochemistry in my hospital, so we only made actin and vimentin, and both were positive. We think that the decalcify process maybe can put some obstacles in the interpretation of this case in the immunohistochemistry, in case we don't have SAT2 and more antibodies. The patient clinical evolution, once we made the diagnosis of a dedifferentiated parosteal osteosarcoma, she received chemotherapy, and posteriorly in the TAC, those multiple nodules that she had previously in the lungs will disappear, and it was only reported a calcified nodule and no other alterations. So in retroscopy, I think that maybe in that second biopsy that I showed to you that was prepared that of a biopsy of the intramedullary component, it was present, this intramedullary low-grade component of the parosteal sarcoma, but we never imagined that this component we saw was more than connective tissue. And that's all. That's it about my case. I expect commentaries, questions, and thanks.
Thank you, Eréndira, for your nice presentation. Oh, okay. So any question or remark for this case? Professor Lombard?
Yes, this is an interesting case. I wonder if you have considered the existence of a malignant leiomyosarcoma as a differentiation of the primary tumor. Leiomyosarcomas are very aggressive tumors and could be one of the possibilities. The histological picture you saw could be also a leiomyosarcoma.
Yes, but you think that the low-grade component is a leiomyosarcoma?
No, that is it's not a leiomyosarcoma. It's a low-grade, it's a parostealosteosarcoma without any doubt. Maybe you could have performed MMD2 and CDK4, which would confirm the diagnosis of this low-grade parostealosteosarcoma, which are positive for these two markers. But I mean, for the internal growth, the neoplasm, the intramedullary tumor, they mimic, from a point of view I've seen in your slides, that could be a leiomyosarcoma.
Yes, leiomyosarcoma was also a differential diagnosis that we made. And now that we have a little more antibodies, we are going to make more immunohistochemistry for the case.
Specifically ME2 and CDK4.
We have made, not in our hospital, in the National Institute, it was made MDM2, but it was negative. And we consider that maybe because the piece was in descalcifying maybe the first time 24 hours, and then because it was still hard and difficult to cut, then we put it again in decalcification. We think that maybe the process of decalcification doesn't permit to interpret appropriately, de manera apropiada la immunohistochemistry.
Eréndira, are you be able to see the chat box?
Huh?
Are you be able to see the chat box?
No.
Is there an equation for you?
No. I will look for the. Yeah. Oh. Well, Doctora Haydee, Caro, this is the first time.
Before.
Okay. What number?
Doctora Silvia Bagué.
See, like a fibroma desmoplastic. Yes, but I think that even both components can express MDM2 and CDK4, but even if they don't express it, I think that morphologically and radiologically, it can be a dedifferentiated parosteal osteosarcoma with a low-grade component. Maybe the process of decalcification will not permit to see the positivity we expect, but I am still thinking that even the immuno will not be positive. The morphology and the radiology and the clinical evolution of the patient, yes, because she responds to the chemio. I think that this can be a low-grade differentiation, a parosteal osteosarcoma with a low-grade differentiation.
Could you also have a look to the next question, please? Dr. Estrada, could you find intramedullary neoplastic bone? This question.
In the intramedullary component, there were no bone, no bone trabeculars. All the intramedullary component was the proliferation of fusocellular cells.
Okay, thank you very much. Any further question or remarks?
Good morning, everybody. And I'm Maria Pacheco from Panama. Thank you very much for the amazing and very interesting cases. Dr. Eréndira, I agree with you that this is a low-grade parosteal osteosarcoma. Although I recently bumped into one case of very similar. It was a case in a young man that had a tumor 10 years ago. It was, and in that time, it was diagnosed as a fibromatosis, desmoid fibromatosis 10 years ago. And I had the fortune to get the recurrent tumor. And the recurrent tumor, it was a high-grade fibroblastic proliferation with a brisk atypia, brisk mitotic count. So I was curious and I went back and looked at the previous case of the young man that had this tumor 10 years ago. And I performed MGM2 on SAT-B2 abroad because I don't have, as like you, I don't have access to this in immunohistochemistry. But it turned out that the case that was diagnosed as a desmoid type fibromatosis 10 years ago, it was actually a low-grade central osteosarcoma, which was completely fibroblastic. And I was really impressed by this case and made a search. And Dr. Bertoni from the Risoli Institute in 1993 described the desmoplastic fibroma-like low-grade osteosarcoma, which is completely devoid of bone. So I think that I really like to think out of the box too, but I think that your case fit perfectly with this entity. So that's just the comment, and I can share the paper if you'd like in the message. Thank you very much.
Okay, thank you very much. Many thanks to all guest speakers and attendees. We have enjoyed really with your case presentation. I hope to see you again in future session. The next session will be in October 20 at the same time, and there will be speaker with expertise in superficial cutaneous sarcoma. So we get a start in the next month. We specific session for cutaneous sarcoma, gastrointestinal sarcoma, gynecologic sarcoma. So for each part of the body, try to integrate this with this IMPERAS project. So thank you very much to all. Professor John, yes.
Let me make a comment. You have devoted this session to Paco Martinez Tello, the late Paco Martinez Tello, who died a couple of days ago. He was a great pathologist, And I think he was the founder of the osteoarticular section of the SEAP, and he worked in the IIP very nicely as vice president for Europe. I think he deserves some special honor, and I suggest to your group and to the osteoarticular group of the SEAP to carry on maybe a session in his honor, or a special issue of the journal Pathologia devoted to soft tissue and bone tumors and honoring his memory. So maybe you contact people of the SEAP. As far as I know, that some of the mentors of the SEAP are present in your sessions and could be take over this initiative, honoring Paco Martinez Taylor.
Yes, more than happy to do it.
Yeah, dear Dr. John Bart, we are trying to organize that for the next Congress in the SEAP Congress in Sevilla, for sure. And I'm sure we can also try to organize the monographic journal that I think can be very interesting for all of us. And he really merits it. So we'll try to organize everything. Thank you.
You're welcome. Thanks very much, Silvia.
Okay, thank you, and see you in the next section.
Bye-bye.
Thank you so much.